Welcome to this episode of ASNC's interview series, Flurpiridaz from 30,000 Feet, an early look at what we know so far. I'm Dr. Rupa Sangani, and I'm Director of Nuclear Cardiology at Rush University in Chicago, along with my co-interviewer, Dr. Hayan Juni. Hayan, would you like to introduce yourself?
Thank you, Dr. Sangani. I'm one of the nuclear cardiologists at Mayo Clinic, Rochester. I'm also active in the ASNC LDP program for this year.
As many of you know, flurpiridaz, the first new nuclear radiotracer in almost 30 years, was recently approved by the FDA. We are incredibly fortunate today to have Dr. Jamshid Madahi, a true expert on this topic, with us today. Dr. Madahi is a founding member of ASNC, is professor of medicine and cardiology, as well as molecular and medical pharmacology and nuclear medicine at the UCLA School of Medicine, and is director of the Biomedical Imaging Institute. He was the principal investigator of the flurpiridaz phase 1 through 3 clinical trials, including the pivotal Aurora trial. Dr. Madahi, Jamshid, if that's okay.
Sure, of course.
Flurpiridaz clearly stands out because many of its unique properties. How do the technical properties of this tracer translate into real-world clinical advantages? And how might they change how we define best-in-class MPI? So what distinguishes flurpiridaz from the traditional MPI agents, such as technetium, rubidium, or ammonia?
Yeah, thank you, Dr. Sangani. I wanted to thank you and ASNC for the opportunity to contribute to this series. I think your question is a very important one. I would just point out sort of a bullet point as to what are the characteristics that distinguishes it from rubidium first and then from technetium second. As compared to rubidium, because of the F18 label, flurpiridaz can be delivered as a unit dose from the regional cyclotrons. Therefore, it eliminates the need for having an on-site cyclotron that is the case with ammonia, and also eliminates the need for a generator, fixed cost generator that is the case with rubidium. Number two, because of the longer half-life of F18, it is now possible to do exercise testing and imaging during exercise that is not easily doable with the other tracers. There are some studies that show feasibility with ammonia, but it is a very cumbersome protocol. But here, it is a very straightforward protocol that we can do exercise imaging with it. The other characteristics of flurpiridaz that help to distinguish it from others is because of its higher spatial resolution. Spatial resolution depends on the amount of distance that the positron travels before it gets annihilated. With F18, it travels about 1 to 2 millimeters away from the target, but with rubidium and technetium, with rubidium, I'm just comparing to PET tracers. With rubidium, that distance is about 7 to 8 millimeters. So you can see that there is some sort of a blurring factor because of the farther movement of the positron from the target that results in a better spatial resolution of flurpiridaz. And the second characteristic is that it has a higher extraction fraction. The extraction fraction is about 94%, while rubidium is in the range of about 65%, and that's the same, similar to technetium 99M labeled tracers. And because of that higher extraction fraction, it tracks flow much better at higher flow rates because of not having a roll-off phenomenon. And also, as we have pointed out in many publications, it leads to a better defect contrast. So therefore, it has a potential for improving defect detection or sensitivity for detecting milder defects. Although when we talk about rubidium, we have to do head-to-head comparisons to check the last few points that I made. From image quality, we know for sure it is better, but whether defect detection is any better has to be tested. But comparing to technetium, then we have to refer to the phase 3 trial, which was a head-to-head comparison. We do have that. And it shows that it has a higher diagnostic performance, especially in females and obese patients. It has a higher image quality as compared to SPECT, and also a higher confidence of interpretation. And more importantly, it has lower radiation to the patient. Radiation to the patient was half in the phase 3 trial with PET compared to SPECT. And then we have the whole concept of quantitational myocardial blood flow that is not available with technetium labeled tracers. And that adds, in my opinion, a very, very important advantage.
Thank you, Dr. Madahi. Now, as you shared with us, we know from the phase 3 trial that flurpiridaz has superior sensitivity compared to SPECT, and particularly performs very strongly in women and patients with obesity. How do you think in the future, who would be the ideal patient for flurpiridaz?
It depends, in my opinion, on what the lab is currently doing. If the lab is currently doing for cardiac imaging or doing technetium labeled agents, and they have a PET system that they're using it for oncology primarily, I think that then the question is that which one of the technetium patients would be switched over to flurpiridaz, and I think that that would be perhaps the starting point for many labs. And that I think that, as you pointed out, women and obese patients have been shown in the phase 3 trial. I would also add that we have data that in diabetic patients also, flurpiridaz performs better than SPECT. Therefore, I think that these would be the 3 groups that I would focus on. But if a lab is doing already rubidium, then I think that the selection primarily is going to be whether they're going to convert the whole lab to from rubidium to flurpiridaz because of the cost of running the economics of it and the fact that they don't need to have a generator. And even if we want to maintain rubidium, then I think that in subgroup of patients that they're interested in looking at myocardial perfusion with exercise, I think that those patients could be studied very easily with flurpiridaz while they cannot be done with rubidium.
Terrific. Jamshid, with flurpiridaz's superior image quality compared to SPECT and the higher resolution, what stands out most to you when you're reading a flurpiridaz PET's case? Are there any interpretive pearls or pitfalls that we need to keep in mind, especially during this early rollout phase?
Yeah, that's a very, very important question. Actually leads to the major topic of education as we get to know this tracer. The first thing that you notice is that the cavity is much better defined. It seems at the first glance that the heart is enlarged because that's the kind of a cavity that we see with technetium tracers, but that is not the case. It's because of the higher resolution. We see a thinner myocardium that is closer to the real thickness of the myocardium. And we also see a larger cavity, which is again closer to the actual size of the cavity of the heart. That's the first thing that you notice. The other one is, so basically that thinner myocardium is because the myocardium is not blurred anymore. So it is more clear. Now, as part of this higher resolution is that the apical thinning, that is a normal phenomenon in all patients, is now more pronounced. Because again, we're removing blurring, so you can see apical defects that appear to be apical defects. So that is the part that the people who are interpreting have to get used to. What is a normal apical thinning? Obviously, looking at the gated study helps distinguish a defect from a non-defect, non-real defect, and being a normal variant. Because of the higher resolution, we have to pay attention to 2 things, and these go into the quality control. I would say that the most important quality control aspects of flurpiridaz are attention to motion, because again, there being a higher image quality, the more it is very sensitive to motion. We actually discovered during our studies that we have 2 different kinds of motion. One is when the patient moves between the studies. The other one is actually the patient is quite still, but during pharmacologic stress, because of heavy breathing, the myocardium and the heart seems to be moving to a different location in the chest and then moving down. It is similar to the phenomenon of upward creep that was described with exercise in the past. So that kind of emotion has to be corrected, and I'm glad to report that this motion correction has become part of the processing and quantification aspect of fluoroperidase. And again, because of the higher image quality, then misregistration is more prone to happen. So it is very important to pay attention in terms of quality control to make sure that the emission study fluoroperidase images are registered properly with the transmission scan.
Thank you, Jamshid. Now, we know the fluoroperidase has really excellent characteristics compared to other imaging tracers. However, implementation hurdles remain a problem, and that can range all from cyclotron logistics all the way to reimbursements. What are some of the challenges in adoption for fluoroperidase that you see in the future?
Right. I think that you pointed out two very important points. One of them is the distribution and delivery to the interested imaging sites and reimbursement. The GE Healthcare, who's basically distributing this, that is distributed through various vendors, so to speak. They have been very proactive, actually, that before the rollout into the clinical arena that happened in late March, they did actually spend quite a lot of time in making sure that the distribution sites are up and running. And I would say that right now, fluoroperidase is available to most metropolitan areas, but they are expanding. It may take a while before all the regional cyclotrons adopt distribution of it, and I think that those are all in place. So I think that there is need for some time so that it is available to the entire population in the US. Now, the private insurances have always been an issue. I'm sure you're aware that even after 30 years of rubidium in the market and use of rubidium, still some of the private insurances call it investigational after 30 years. So I think that they would probably have a pushback, but I think that the data is very strong, and we're hoping that most private insurances will actually join the reimbursement effort. Then the other challenges, as we pointed out before, is education. I think that education is not going to be difficult, but it is something that ASNC is taking a leading role with the workshops that they have, multiple workshops and so forth, that education is very well addressed. At the end of this session, there will be some links that the attendees can access that will give them some of the guidelines in this regard, give them access to the main publication of the pivotal trial. And also, we just finished the practice standards for fluoroperidase document that is going to be a multi-society document by SNM and General Nuclear Society, about ASNC, SNM, and other European societies, and that is going to hopefully become available. The draft is complete, and it is probably waiting in line to be published, and that would be a very good resource for education. Now, the other things that we have to simultaneously work through, one is if you do exercise with fluoroperidase, there is an issue of increased radiation dose to the staff, because when they inject the patient, they have to be next to the patient, monitor the patient through 2 minutes of exercise and during recovery. But with pharmacologic stress, they can do it all remotely. But with exercise, they have to be there. So the question is that, can we make that remote? How can we protect the staff with the increased exposure, because they're going to be next to the patient with F18 in their body? And the other thing is that the protocols will be refined. The way we designed the trial and the way it was done, it required certain types of protocols because we wanted to adapt to all types of equipment that is in the market. And now I think that with the advances, since we started doing this protocols more than a decade ago, I think that now we can shorten the protocols. We can now draw protocols in place. And one of them was presented at the Society of Nuclear Medicine was a protocol that with image subtraction or spillover subtraction, you can finish the entire study with the pharmacologic stress in about 20 to 25 minutes. So I think that that becomes a very important challenge, but I think that it is being handled right now. So I think that in the future, we'll be able to do the protocols more, I would say, more robust protocols. Maybe stress only would have a role in here, and that would be, again, another important aspect that is being worked on currently.
Jamshid, thank you so much for providing your expertise and insights on this episode of the ASNC interview series. This is such an exciting time in nuclear cardiology. As Jamshid already mentioned, obviously referencing the actual Aurora trials, the ASNC F18 educational seminars to help with your interpretive ability, and then referencing the ASNC lab considerations on F18 radio tracers and the upcoming SNMMI document provide a wealth of resources as you embark with this new tracer. Thank you also to ASNC, our listeners, and to Hayan, my co-interviewer.
Thank you very much for including me in this series.